Thank you for standing by. At this time, all participants are in a listen-only mode. After the presentation, we will conduct a question-and-answer session. To ask a question, please press the star one and please record your name. Today's conference is being recorded. If you have any objections, you may disconnect at this time. I would like to introduce your host for today's conference, Dr. Richard McCann. You may begin.
Thank you very much. This is Dr. Richard McCann. I'm the Chief of the Suicide Prevention Branch at the Substance Abuse and Mental Health Services Administration. I'm very pleased for us to be able to present this webinar to you today on an extremely important topic. We are privileged to have two of the real leaders in the field of suicide prevention here today with us. First, we're going to hear from Dr. Thomas Joyner, who will be talking regarding his theory regarding why people die by suicide. And I think that is probably one of the most central questions in suicide prevention, one that people ask themselves all the time to try to somehow come to grips and grasp how this tragic event can take place. And as I said, we're privileged to have Dr. Joyner with us. He is, I think, without question, the leading theoretician around suicide currently. He is also an expert researcher, but I think the thing that I would really like to underscore is that for research to be effective, oftentimes, you need to know what you're looking for. You need to know what questions to ask. And to have that, you need a good, coherent scientific theory in order to point that out to you. And I think that Thomas has really done seminal work in his theory on why people die by suicide, which we'll be going over with you today. Now, Thomas's theory, I think, has implications across the board for suicide prevention, for treatment, for assessment, and for intervention. But we are privileged as well to have Peter Wyman, who is one of the leaders in the prevention of suicidal behavior, with us to serve as a discussant to talk about the implications of Thomas's theory for suicide prevention efforts. Of course, for us, this is particularly important at SAMHSA as we fund our Garrett Lee Smith Memorial Grants for youth suicide prevention. And so knowing what are promising approaches for the future that could potentially be utilized is of tremendous importance for us and for the nation as a whole. So with that as kind of a preamble, let me just give you a very brief rundown of the illustrious biographies of Dr. Joyner and Dr. Wyman. So Thomas Joyner is the Robert Lawton Distinguished Professor in the Department of Psychology at Florida State University in Tallahassee, Florida. He has worked on the psychology, the neurobiology, and the treatment of suicidal behavior and related conditions. He is also the director of the Department of Defense-funded Military Suicide Research Consortium, which is doing extremely important work right now to help us better understand death by suicide within the military. And he's authored or edited 17 books, including Why People Die by Suicide, published in 2005, and Myths About Suicide, published in 2010. Following Thomas, Peter Wyman will be our discussant and offer his views on the implications of Thomas's theory for prevention specifically. Peter is the professor and director of the School and Community-Based Prevention Laboratory in the Department of Psychiatry at the University of Rochester School of Medicine and Dentistry. His research interests are on conducting generative psychosocial research and translating research findings into community-based, public health-oriented preventative interventions. He currently leads an NIMH-funded effectiveness trial of a universal suicide prevention program, Sources of Strength, in 36 rural communities, and is testing variations on safe suicide prevention messaging and methods for sustaining sources of strength in rural schools through funding from the Center for Mental Health Services of SAMHSA and from New York State. He serves on the Scientific Advisory Board of the American Foundation for Suicide Prevention, was a topic expert to the National Action Alliance's Task Force on Research, and organized a national expert panel to examine the rationale and feasibility of expanding the current U.S. suicide prevention paradigm to include a focus on earlier upstream prevention approaches. So I think this is going to be a fantastic webinar. And with that, I'm glad to introduce Dr. Thomas Joyner. Thomas?
Thank you, Richard. I really appreciated that. I have a lot of respect for Richard McKeon and for Peter Wyman, and to be a part of a panel with them is an honor for me. And I'm looking forward to being able to share with all of you this morning a very accessible, down-to-earth overview of the theory that Richard alluded to, that I and my students and my colleagues have been working on over the past 15 years or so. The talk's called Why People Die by Suicide. That's an ambitious title, but it is an ambitious model, and the ambition is to provide at least one way of explaining or answering this very important question. Why is it that we lose our loved ones, our family members, our friends, our men and women in uniform, our veterans? Why are we losing so many to death by suicide each and every day? You see my contact information there, by the way, on the slide. At the bottom is my email address, and that's just for your general information. So with that, I'm going to dive into the material. On February 1st, 2003, the space shuttle Columbia disintegrated as it flew over the western U.S., and it finally came down over East Texas and Louisiana in thousands of pieces, and on that day we lost all 7 crew members on Columbia. The image there is actually a National Weather Service image from February 1st, 2003, the day of the tragedy. And the green portion is actually not very remarkable. That's there every day. That's the ground clutter that's around Shreveport, Louisiana. It's the reddish-orangish portion of the image that's remarkable. And it looks like a storm front, but it's not. It's the debris trail of Columbia. As many of you will recall, this tragedy boiled down in terms of causation to a piece of foam. The piece of foam was not very big. It was it weighed a couple of pounds. It was about 19 by 11 inches wide. It had the feel and the heft and the size of an empty briefcase, basically. The trouble was not the size of it. The trouble was the speed of it. It came off of Columbia's left side, and it hit the left wing on takeoff at 545 miles per hour. And we now know in retrospect that opened up a breach in Columbia's left wing. The shuttle made it up into orbit, very successfully accomplished its 2-week-plus mission. It was on re-entry that breach allowed superheated gases to penetrate the wing, took the wing apart, took the shuttle down, and killed our astronauts. One very important aspect, let me go back for a second, one very important aspect of this catastrophe was that it was caused by a piece of foam, and what's come to be known foam strikes were very well known to NASA. They had been occurring pretty regularly throughout the 80s and into the 90s up to 2003 when this tragedy occurred. Foam strikes have become well known to NASA administrators and others. Now, of course, this disaster was investigated thoroughly, and I just want to read the words of one of the panel members who were in charge of investigating the accident. And he's talking about foam strikes, and he said, "The excitement that only exists when there is danger was kind of gone, even though the danger was not gone." NASA actually had some idea that there might have been a breach in the wing, and they debated whether to get in-flight imaging or even to take a spacewalk to have one of the astronauts look at the left wing in orbit, but they decided against doing that. And the reason that they decided against it had in part to do with the fact that their sense of danger about foam strikes had eroded over the years. And the reason that their sense of danger had eroded over the years is because they had repeated experience with foam strikes. They got used to them. They habituated to them, in other words. And one thing I want to do with you all this morning is to draw kind of a connection between the process and the disaster that was Columbia on the one hand, and on the other hand, the processes and the catastrophe that is death by suicide. And one of the key ideas is mentioned on this slide. And the idea is that just as NASA became unconcerned, relatively unconcerned, about something that in the end, of course, was very concerning, indeed it was catastrophic. Similarly, through a similar process of getting used to something that really you shouldn't get used to, suicidal people become unafraid of threat and danger. I'm going to talk more about how that happens, but the words that I use to describe that process are there on the slide: the acquired ability for suicide, or sometimes I say the acquired capability for suicide. This is an important novel aspect of the model that we'll delve into in a little more detail in just a second. But before I do that, let me back up a step and reflect for a minute on what counts as a good scientific theory. And what's depicted on the slide is a very brief summary of a whole field called the philosophy of science. And this doesn't cover everything, but it's a pretty good workable definition of how to evaluate good theories. They should explain things that heretofore were unexplained or confusing or perplexing. And I've listed some of those with regard to suicidal behavior on the next slide. For instance, why would it be, and this is a fact, it's a perplexing fact at first, but it's a fact that female physicians and female prostitutes, two groups of women who have very little in common, do have in common this one thing, and it's high rates of death by suicide. That's an empirical fact. It's at first a puzzling one. Why would it be that female physicians and female prostitutes have anything in common? They have this in common: similarly high rates of death by suicide. And the question is why. Good theories of suicidal behavior should come along, new ones, and explain some of these at first perplexing kinds of questions. Incidentally, this bullet point, this first one, focuses on female physicians, but I should add that male physicians have quite high rates too. And you could pose that as a puzzling question. What is going on with physicians that they have such high rates? They're rich, they're well regarded, they have good access to health care, including mental health care. Seems like they'd have lower rates, but they have higher rates. Puzzling until you focus on some of the facets of the model that I'm going to get into in a moment. That second bullet point's an interesting one too. Why would it be that suicide rates decrease in times of national crisis, which they surely do? If you go back to September of 2001 and you look at the U.S. daily rates on September 9th, September 10th, and then September 11th, 2001, you see a remarkable thing happening. On September 9th, which if you remember was a Sunday, we lost about 90 of our fellow Americans to death by suicide on that one day alone. That's a lot of people, incidentally, for just one day and just one country, underscoring that this is a massive public health problem. Same thing more or less happened on September 10th, Monday, September 10th, more like 95 deaths by suicide among our fellow Americans. But then on September 11th, an unheard of thing happened. With regard to the suicide rate, of course, it was a day of national shock and tragedy. Suicide rates went way down. We had about 30 or so deaths by suicide around the country on that fateful day. That's what happens when countries are in crisis. The suicide rates don't go up, they go down. And believe it or not, this last part of this second bullet here on the slide, suicide rates go up when a city's sports team or a region's sports team or a state, their sports team dashes local expectations. You can detect an actual increase. It's small, but it's detectable in suicide rates in that locale. So a good theory must answer questions like that, but a good theory also has to be compatible with known facts about the phenomenon in question. Here it's death by suicide, and I just wanted to lay out a few such facts. They're interesting in their own right, and they're good ways to evaluate new theories. Good theory has to be compatible with these facts. As a general matter, suicide rates are highest in older people. There's a rule of thumb that this is a cause of death that affects a lot more people in the last half of life than it does in the first half of life. That's a well-established fact, as is that second point, where, with the possible exception of China, some years they have about an equal suicide rate among men and women. All other countries around the world that have been well characterized, in those countries, this is a male-linked phenomenon, much more common. Death by suicide is much more common among men than it is in women. In our country, for instance, the ratio is 4 to 1. For every one woman who dies by suicide, 4 men do, more or less. And that's quite an imbalance. That's an empirical fact that really cries out for some kind of theoretical explanation. There are ethnicities that are more vulnerable than others to death by suicide, but they're not the ethnicities that may have occurred to you immediately. They're listed there on the slide. People of Native American descent and people of Caucasian descent have the highest rates, and other ethnic groups, relatively speaking, have lower rates. This fourth bullet point has to do with a personality characteristic called impulsivity. I believe that, by the way, impulsivity, if you don't know what it is, it's just a personality tendency to act rashly without much forethought. You just kind of act without giving it much consideration. And there's been some empirical work, some research linking that personality trait to suicidal outcomes, but I think that's misled our field to imagine that a lot of suicidal behavior is literally impulsive, literally on a whim. In other words, people are just dying on the spur of the moment without much consideration or reflection or planning. And I think that's a misunderstanding. I think that to do something as fearsome and daunting, it's just scary, as to face death. It's hard to do that, very difficult to do that without considerable reflection and planning. Now, deaths by suicide, incidentally, there's no question that they come out of the blue and shock and stun family members. There's no question about that at all. But that's a different matter than impulsivity. Those deaths very well could have been planned in the minds of the individual without the individual disclosing those plans. So it didn't happen suddenly from the perspective of the individual. It happened suddenly from the perspective of everybody else. Later in this talk, I'm going to delve a little bit into the difference between the suicide rate in anorexia nervosa versus bulimia nervosa. Those are eating disorders, anorexia being a self-starvation syndrome, more or less, bulimia, a binge purge syndrome, more or less. Both eating disorders, and you might think, therefore, that they should be similarly linked to risk for suicide, but they're not at all, really. Anorexia is much more of a risk for death by suicide than is bulimia. Again, these are empirical facts, and a good theory should come along and shed light on facts such as these. One more fact, and I've already alluded to this, but it bears repeating, that death by suicide, while in one sense relatively rare, we lose 100 or so of our fellow Americans to death by suicide every single day, and of course that's just one country. It's a lot of people, but relatively speaking, it's a rare cause of death. The number that we lose in the U.S. alone, the heart disease, for instance, is approximately 2,000 per day. It's a relatively rare cause of death, and therefore theories of suicide have to be able to account for why it's a relatively rare cause of death. This slide's an important one for my lecture because it's a visual summary of the entire model. It's an attempt to boil down the concepts into one visual image in one slide. So I'm going to leave this up there for a while and talk about each of the components and just make some remarks about each aspect of the slide. Let me start on the right portion of it, where it reads, those who are capable of suicide. It's in that reddish, pinkish portion. It could very well have read, maybe I should have changed it to read, fearlessness of physical pain, physical injury, and of death itself, because that's really what I mean by that. This part is the part that I was drawing the analogy earlier with the shuttle disaster. The idea on the right side of the model is that death by suicide is inherently very, very fearsome, scares people, it daunts people. Therefore, in order to enact it, it logically follows that people will have to have developed a fearlessness of death and a fearlessness of the physical injury and the physical pain that it often entails. And I'm going to go into a little more detail in a moment about how it is that people develop this fearlessness of physical ordeal. On the left side of the slide, a different matter is addressed. And the question there is, apart from capability, the right side of the model is about capability. Who would be capable of this very fearsome behavior? The left side of the model addresses a different question, and the question there is, why would anybody want to in the first place? Regardless of capability, why would anybody want to enact death in the first place? And the model has two answers to that, and they're listed there in that orangish, yellowish circle. The terms are perceived burdensomeness and thwarted belongingness. Let me describe those in a little bit of detail briefly, and then I'll make some more comments about how it all fits together. Perceived burdensomeness, a good way to think about it is it's a state of mind where you believe, you truly believe it to be true that your death will be worth more than your life to other people. In other words, you feel like you're a liability, like you're a burden, in other words, and that death will remove that liability or that burden from others. Now, let me harp for a moment on the word perceived. So, the model does not claim that suicide decedents were actual burdens. As some of you may know, this runs in my family very strongly. I would never make such a claim. The claim, rather, is that suicide decedents in the moments before their death are under the mistaken impression that they're doing everybody a favor. But they don't know that they're mistaken, and they act on their belief that they're a burden, and that belief is a factor in their deaths. Thwarted belongingness, also an interpersonally relevant state of mind, and this one is the state of mind that you're hopelessly alienated, hopelessly cut off and socially isolated from others. And then when you put those two things together, when you have those two states of mind, perceived burdensomeness and thwarted belongingness, simultaneously in the mind, and you have no hope that they will change in the future, that, according to the model, is why people desire death. But a crucial prediction of the theory is that even people who desire death very, very intensely can't enact it unless they also have developed the fearlessness needed to face physical ordeal, the fearlessness of death. Even if you have a lot of risk on the left side of the model, you'll get stopped in your tracks because death is so scary unless you have risk on the right side of the model. So it's only people in that little area of overlap in the middle there that are at risk for serious attempt, near lethal attempt, or death by suicide. And notice, by the way, that that's very nicely consistent with the relative rarity of death by suicide. Why is it rare? Well, it's because these two circles are pretty rare in themselves, and then when you factor in their confluence, their overlap, it's even rarer still. That's why this is a rare thing, because it requires specific, relatively infrequent conditions to co-occur in the same individual. And then one last detail about this slide, notice the relative sizes of the circles. The reddish oval, pretty small. The orangish circle, pretty big, suggesting that fearlessness of death on the right side of the model is a pretty rare thing, even more rare than desire for suicide. The idea there is that we are, as creatures, are just naturally designed to fear pain, fear death, fear injury. Indeed, we have specific brain structures that underlie those fears. It makes sense. It helps in survival to be afraid of those things. And so to be unafraid of it is pretty unnatural and pretty rare, more rare even than the desire for suicide, which rare itself is a little more common than fearlessness of death. All right, so let's drill down into each of these three in a little bit more detail, starting with the right side of the model, which again is about fearlessness of physical ordeal. An important concept here is a pretty obvious one called habituation. I've got the formal definition listed there on the slide. It's a response decrement due to repeated stimulation, but a better way to say it perhaps is it's just getting used to something. You have experience with something, even something noxious or negative. If you experience it enough, it becomes kind of mundane. Even something that's painful, if you experience it enough, it becomes rather mundane. And I have these two creatures depicted on the slide because, as primitive as they are, they can quickly learn via habituation, and so do humans learn via habituation. With regard to suicide, when you're repeatedly exposed to things like pain, things like injury, things like imagery of death itself, what that has, the effect that has is that it starts to erode the taboo and the prohibited quality of suicidal behavior. And it also starts to diminish the natural fear and even the natural physical pain that people feel when they're injured. So that's habituation, getting used to something. It's a simple process. The model claims that it's centrally involved in the development of fearlessness about death. But there's another process that's a little more complicated. I'll describe it, and I'm going to give you an example that I hope will bring it home. It's at the bottom of this slide called opponent processes. And basically, in a nutshell, this theory, it's called opponent process theory. It predicts that with repetition, a provocative stimulus, its effects will diminish. Basically, habituation, but it goes one step further, and this is where opponent process comes in. It also predicts that there's going to be another effect, an opposite effect, and that with repetition, this effect not only does it not weaken, it becomes amplified and strengthened. Now, that's a little hard to get your head around, so think about skydiving as a concrete example. That's something that we were not wired to do, is dive from a height of 10,000 feet. It's unnatural. And yet, people do it, and they get used to it. That's the primary process of habituation. The more you do it, the less fearsome skydiving becomes. But there's an opponent process, too, with skydiving. And with regard to skydiving, it's thrill or exhilaration. The more you do it, the more the thrill kicks in. It kind of becomes addictive almost to some people. So the first time you go skydiving, mostly you feel fear, because that's naturally what humans were designed to feel when they look down over a visual cliff. But you also feel a little twinge of thrill. Fast forward to the 20th episode of skydiving. What's happened to the fear? Diminished. What's happened to the exhilaration and thrill? Amplified and strengthened. That's opponent process theory in a nutshell. What applies to skydiving can also apply to self-harm. First time you do it, pain, fear, lots of negative emotions, but also a little twinge of self-harm's opponent process, which is calming, soothing, pain-killing. That's why people engage in the behavior. And then fast forward to the 5th or 10th episode of it, a lot of the fear and pain have gone away, and the opponent process of calming, soothing, pain-killing has amplified and strengthened. This is an example of these processes, a tragic one. Many of you will recognize Kurt Cobain, who led the group Nirvana in the 80s and 90s. This is him a few months at a photo shoot with one of the guns that he owned at the end of his life. He died by self-inflicted gunshot wound in the early 90s at the age of 27. A famous fellow, but a lot of people don't know this about Cobain, that as a kid, he was a temperamentally fearful child. He was clinically afraid of needles, clinically phobic of heights, and he also is very fearful, even phobic perhaps, of guns. But through repeated exposure, a child who initially was afraid of these things, needles, heights, guns, later became quite unafraid of things like needles. In fact, he used them every day to inject heroin. Unafraid of heights, he would climb and dangle from scaffolding, and during concerts, 30 feet up, even 50 feet up in some examples. And he also became somebody who was not just, unafraid of guns, but who had a real appetite for gun ownership. He enjoyed guns. He enjoyed gun magazines. He owned several. And let's delve into his history with guns, because it's an illustration of habituation and also opponent processes. So he started out as a child feeling that they were barbaric, and he wanted nothing to do with them. In fact, he wouldn't even enter a house. He wouldn't set foot in a house if he thought there was a gun in there. Later, when he was about 14 or so, he agreed to go with his friend to shoot guns, but he refused to get out of the car. He's taken a step, but still pretty fearful. Later still, he would get out of the car, but he would not handle the weapons. Another step, but still some fear. And later still, he agreed to let his friends show him how to aim and fire the weapons. And still later in his life, late teens, early 20s, he became a gun enthusiast. And he did, in fact, die by self-inflicted gunshot wound in '94 at the age of 27. Now, this slide and the example of Cobain's relationship with guns, nothing to do with gun rights, the Second Amendment, any of that. It's just simply an example of habituation and opponent processes with regard to a provocative stimulus. A person originally afraid of something develops not only a fearlessness of that, but also an active taste and appetite for it. This is a little bit of a parenthetical slide, but just wanted to take one moment to note the due diligence that my students and my colleagues and we feel we've done with regard to scrutinizing this model empirically. And we've got a lot more than just these 4 scholarly publications on the model. But I just wanted to at least have this in there to note that we're doing our due diligence, and so far the model is holding up well. These journals may not mean much to you, but they're exclusive and difficult outlets in which to place papers. So we feel that we're doing our due diligence with regard to empirical scrutiny of our ideas. There are a couple of examples anecdotally that I wanted to mention, and they're a contrast to one another. One is an incarcerated young man, incarcerated for pretty brutal physical assaults. And he's being interviewed about his history of self-injury, and he notes in a cool demeanor, calm tone, that not only does he regularly engage in behaviors like self-cutting and self-bruising and self-burning, but he ingests objects, all sorts of objects, ones that are going to do quite a lot of damage to him internally, things like razors and bed hooks and the like. He says these things really with no tinge of suicidality to him. He's not talking about death. He's just talking about a self-harm behavior that's designed for something else. And when he's asked, well, what is that something else? Why are you doing that? He actually has a lot of insight to it. And he says, I do it because it helps me feel better, and also because it changes my environment a little bit. It gets me into a better hospital situation as opposed to a prison situation. Fairly honest and insightful answer. But keep him in mind as a point of contrast to, for example, this scene from the video documentary The Bridge. It's a documentary about the death by suicide from the Golden Gate Bridge in San Francisco. And one of the dramatic aspects of this film is a scene where a woman is on the other side of the railing of the bridge, just one step away from her almost certain death by suicide, and somebody intervenes. A good Samaritan intervenes and pulls her back over the railing. And as she does it, she shows a lot of ambivalence about death and life. Part of her wants to struggle against the rescuer so that she can continue what she had planned and die. But part of her clearly wants to be saved too. She, in fact, some of her behaviors help the rescuer get her back to safety. Now, if these two folks had changed places, if the incarcerated young man had been in the bridge scene, my guess is that he would be lost to us now, because he has no ambivalence about self-injury. He's developed that physical fearlessness that I was talking about earlier, whereas the young woman in this example has not, and the fact that she got stopped in her tracks saved her life. I want to return to the point about anorexia nervosa. I mentioned it at the outset. It's a pretty lethal syndrome, anorexia is. There's what's called the standardized mortality ratio. SMR stands for standardized mortality ratio. It's high. In some studies, as high as 60, meaning that people with anorexia have 60 times the chance of early mortality as compared to matched samples. So that's a lot of lethality and danger. Most assume that that's being driven by self-starvation, and some of it is. Some piece of that mortality is being driven by self-starvation, but most of it, the vast majority of it, is not. The vast majority of it is being driven by what you might call conventional death by suicide. Why would this be? My group pondered two possible explanations of this high association between anorexia nervosa and conventional death by suicide. And one idea we had was that perhaps anorexic women die by suicide at high rates because they're frail. They're physically weak and fragile. Of course they would be, having been starved for days and weeks, and in some cases months and years. And therefore, they can't survive even very low lethality attempts. A mild overdose, for instance, a thing that most people would survive. Maybe that's part of why there's such mortality with suicidal behavior and anorexia. But we had another view, and it was informed by this theory of suicidal behavior, and it was that maybe women with anorexia, most people with anorexia, incidentally, are female. It's about a 9-to-1 ratio. Maybe they're dying at high rates because their histories of self-starvation have habituated them to the pain and injury necessary for death, and it drives them to make particularly lethal suicide attempts. So we've got two rival explanations, and we had a chance to arbitrate between the two in a study of 239 anorexic women who were followed from about age 20 to about age 35. So this is about 15 years of a follow-up. And during that 15-year follow-up, 9 of the 239 died by suicide. This was by far easily the leading cause of death in this sample. And it's also a really high suicide rate. 9 out of 239 at first glance may not seem high, but it's very high. You should really not see hardly any deaths, 0 or 1 maybe. In a sample of 239 young women, we saw 9. But the question is, of these 9, what were the methods? Were they low lethality things that are killing the women because they're so fragile and physically frail, or were they very highly lethal methods because they're fearless about bodily ordeal? It's the latter. The answer to this is they're highly lethal methods. I'm going to describe the least lethal method, and it's still quite disturbing and very violent. It involved the ingestion of a full container of a very powerful household cleaning agent. This is a powerful enough agent that it affected her internally to the point that she bled out internally and could not be saved. This is a very, very difficult and awful thing and painful thing to go through. And this is the least lethal method among these 9, leading us to think that there's something to anorexia that are making people particularly careless and fearless about their bodies. I mentioned ambivalence a moment ago when I was describing the young woman at the bridge who hesitated. Even someone who, like this, who's able to ingest a full container of a very powerful cleaning agent, even she had a moment of ambivalence. She ingested the cleaner, an extremely difficult thing to do, and then moments later her next behavior was to call 911 for rescue. And in fact, they did come and get her to the hospital, but she died there a few hours later. So that's enough on the right side of the model, that the part that claims that fearlessness of suicide is a really important aspect here. I want to talk in a little bit less detail, a little less time devoted to the desire portion, but I at least want to delve into each of perceived burdensomeness and thwarted belongingness a little bit, starting with perceived burdensomeness. Now, again, just to remind you that the essential calculation in the mind here is my death is worth more than my life to others, to loved ones, family, society. That's what suicidal people believe to be true. It's not true, but they don't know that it's not true. And I mentioned at the outset, or actually I didn't, but there's all sorts of strands of evidence supporting this aspect of the model, and one's briefly described on this slide. There are lots of societies who sanction ritual suicide among members of the group who have become sick or hurt, and the explicit rationale in every documented case of this is burdensomeness. Every single society that has developed this sanction has rationalized it. They've explained it with reference to burdensomeness, every single one. That idea of perceived burdensomeness is intuitive enough that I think I'm going to move on and talk a little bit about thwarted belongingness, which, remember, is a sense of hopeless alienation from others. And this study illustrates its power in a kind of unique way. It was a study of nearly 1 million women in Norway, and they followed up these women over 15 years and documented over 1,000 deaths by suicide. And their interest was on protective factors. At least one thing they were interested in was protective factors. In other words, what deterred women from death by suicide? And one of the most powerful protective factors was having 6 or more children. 6 or more children, you would think that might actually stress them out, burden them, burn them out, etc. But it had a very protective effect. Look at the reduction in risk of death. 1/5 the risk of death as compared to other women. That's a massive reduction in risk. Why would it be that women with so many children have such a massively reduced risk? One possibility is that if you have a lot of children, belongingness is high, and belongingness serves as a protective factor. Now, if you just stop there, you would have questions. There might be other explanations for this association. So let's see if there are other strands of work that triangulate in on this same story. Here's another one. It's a true fact that identical twins die by suicide at slightly lower rates than others. That's kind of an interesting fact in its own right. But they do so despite having slightly higher rates of mental disorders. That's kind of perplexing if you think about it for a moment. Higher rates of mental disorders, that should confer higher risk for death by suicide, but twins have lower risk for death by suicide. That presents a little bit of a puzzle. And the puzzle is potentially solved by the idea that despite the risk of higher mental disorders, twins have lower suicide rates because they have each other they belong to one another, and indeed there is a special quality of closeness and belongingness that most twins report with one another. I mentioned sports at the outset, and those of you who are sports fans know that there can be a considerable amount of belongingness from being a fan of a local team or a regional team, and this is particularly true under conditions of success. And so we and others have done studies linking teams' success rates to the local suicide rates, thinking that team does well, people pull together, and belongingness goes up, and then suicide rates go down. And also the converse happens. People pull apart in the face of defeat, belongingness goes down, and then suicide rates might go up. And in fact, this has been documented in far more studies than what I'm depicting on the screen right now. These are just a rather dated sampling, but it's a really well replicated finding that when the local sports team does kind of relatively poorly, you can often detect an uptick, increase in the local suicide rate. That first study that my colleagues and I did, I'm just going to read the title of it so you get the gist. It's called On Buckeyes, Gators, the Miracle on Ice, and Super Bowl Sunday. Pulling together is associated with lower suicide rates. Buckeyes, Gators, of course, those are college football teams, and we showed that in those local areas, when those teams did well, suicide rates dropped. When those teams did poorly, suicide rates increased. The Super Bowl Sunday effect is just showing that Super Bowl Sunday has lower rates, suicide rates in the U.S. as compared to the Sunday before it and the Sunday after it. We think the mechanism there is people are pulling together around the Super Bowl. Indeed, up to about half of the U.S. population attends some sort of social function on Super Bowl Sunday. It's starting to approach Thanksgiving in terms of its popularity in terms of social gatherings with family and friends. And then there are other studies there. The Miracle on Ice part I'm going to just show you a little bit about. For those of you who don't remember it, it's the Winter Olympics in 1980. It's the Soviets against the U.S., and it's a great David and Goliath story. Goliath was the Soviet Union. They had this hockey machine that should never have lost to our guys, but they did on February 22nd, 1980, and it was quite a celebration. It was a celebration because it was a great sports event, but it was also politically resonant. On that time, remember 1980, we're in the teeth of the Cold War. Our hostages are still in Iran. The Soviets are into Afghanistan, so it was politically kind of meaningful in a way. And so my students and I wondered, might that date, February 22nd, 1980, might that be special? Might it be the February 22nd in recorded U.S. history with the fewest deaths by suicide on that date? And indeed it is. This graph's a little busy, but let me just set it up for you a little bit. On the up and down axis, you got the number of daily suicides, range from at the bottom 60 on up to over 100, and then across the bottom are February 22nds of different years, of the 70s on the left side of the slide up to the 80s on the right side of the slide. And so the suicide rates are just plotted by year here, and it's a little hard to see, but right in the middle of the graph is the low point. That little point downward is the lowest point, and indeed it happened on that particular February 22nd, the day of the Miracle on Ice, and it's the lowest number of deaths by suicide ever recorded on a February 22nd before or since. This graph kind of catches your attention for other reasons, too. There are peaks, pretty big ones, too. On the far right, there's a really big peak, February 22nd of 1988, and then there's another pretty big peak on February 22nd of 1977. It's interesting to speculate what's driving those peaks, but one driver of those peaks is a kind of surprising one, and it's described on this slide. It's a day-of-the-week effect. But just to orient you here, again, you got number of suicides on the up and down axis, and then now those numbers are plotted by average number on day per week, ranging from Sunday across the bottom all the way through Saturday. That red line right through the graph at about 90, that's the mean, the average daily number. And some days are above average and other days are below average. And the two that are above average are Monday and Tuesday. Monday and Tuesday are a weekly suicide peak, every week, week in and week out. Now, going back to that previous slide, the right-handed peak at February 22nd, 1980, that's a Monday. That's when the date happened to fall on a Monday. And then the next biggest peak in 77 is a Tuesday. So those are day-of-the-week effects, at least in part. Speaking of variation by time, I deleted the monthly one, but I was going to make the point before I get to this next slide that there's a monthly peak too, and it's different than what the media will have you believe. The media will often portray the holidays. December, January is the peak, when actually that's the low point of the year. The peak is in the late spring, early summer. Notice, incidentally, what's going on in November, December, and January is a lot of pulling together around family and friends, and that reduces the suicide rate. Starting to close here, I'm looking forward to turning it over to Dr. Wyman in a moment for comments and questions and discussion, but then also for some of the questions from you all. I did want to note first, though, that although I've been really focusing on the three prongs of my theoretical model, my implication is not that these are the only three things that matter. They matter a lot, but there are a lot of other factors that have been documented risk factors. Mental disorders, for instance. I mentioned anorexia. You could mention major depressive disorder, bipolar spectrum conditions, borderline personality disorder, schizophrenia. And there are others, too, that are clearly risk factors for death by suicide. There are genetic factors. There are personality factors. There are life experience factors, and so forth and so on. The claim of this model is that all of those other factors, referred to here as distal factors, the claim of the model is that those distal factors, they operate on outcomes because they operate on those three theory-based variables there in the middle of the slide: burdensomeness, belongingness, and fearlessness of death. Quick note about some of the clinical, prevention, intervention, and risk assessment implications. It's a simple, down-to-earth idea that if this model is true, then anything that even a little bit increases one's sense of belonging or increases a sense of contributing or purpose or mission, which we view as the opposite of burdensomeness, increased belonging, increased sense of purpose, increased sense of contribution, the model's logic dictates that if you do that, you're going to decrease suicide risk and thereby prevent its misery. I'm going to stop there and turn it over to Dr. Wyman.
Okay, Peter, feel free to go ahead.
Okay. Tom, thank you very much. That's really a fantastic presentation. I'm really honored to discuss Tom's work. As Richard really correctly observed, it's difficult to overestimate the impact of the interpersonal theory of suicidal behavior on the field of suicidology. The testament to Tom's creativity, skill, and commitment to saving lives. The interpersonal theory has mostly been known for its major contributions to conceptualizing processes that lead to suicidal behavior. And in my view, the major strengths of those include viewing individuals embedded in a social environment in a meaningful and deep way, and in specifying detailed processes that, as Tom so articulately talked about, accelerate lethality of suicidal behavior, that capability to engage in lethal behavior. I want to present one example here on slide 2, that in the recent Department of Defense report, there's a very large emphasis there on the importance of intimate relationship disruptions, and it's the Department of Defense report in 2012 reports that 47% of military personnel who died by suicide in 2011 had a known failure in a spousal or intimate relationship. And while I don't think I have the evidence to say this is caused by Tom's theory, I think there's little question that this theory, the carefulness with which it's been developed, and has really heightened appreciation for the importance of social ties and disruptions. That it wasn't that long ago when primarily we had discussion about the importance of psychiatric problems, of depression. Those are important factors that increase risk, but I think Tom's work has really shown that we need deeper models that really capture the importance of social relationships and these other processes. My comments are going to focus a bit on what are some of the strengths for prevention, and my area that I know some things about are prevention, particularly with adolescents and young adults and childhood prevention programs. And I see some major strengths of the theory that we should be using and will be using in meaningful ways. And one is that the strengths of the theory in tying processes to earlier developmental life antecedents, clearly the attachment and self-regulation processes, how children learn to manage behavior, behavioral control, manage emotions. These are normal processes that interventions can have impact on. And so there's the potential for large prevention impact if we can harness those and make a difference in those processes at the right time and in the right combination. If we go on to slide 3, please. Why is this important? And I'm not going to spend a lot of time on this, but essentially, as it's widely known, and I think Richard has also been and SAMHSA, a very strong advocate for really our scrutinizing and expanding where do we need to go in suicide prevention. Currently, most suicide prevention has been focused primarily on individuals who are already suicidal or quite far along in the risk process. Most states are implementing gatekeeper training programs. There's a lot of screening, and we need to be strengthening and improving those kinds of programs. But it's unlikely that we're going to solve or dramatically reduce the suicide rates unless we also focus earlier on upstream processes and reduce the number of individuals who enter these suicidal pathways early by making a difference earlier in life and through strengthening and promotion. And the 2012 National Strategy Strategic Direction 1 addressed this in recommending that a focus be on promoting healthy populations to reduce behaviors leading to suicide. And that's a major change, an important change in the national strategy. Let's go on to slide 4, please. This shows the continuum from treatment to prevention and maintenance. And the point here I wanted to make is that most suicide prevention activities are really focused on the early treatment, case identification, identifying individuals at high risk, and relatively little at early prevention, universal programs that are targeting really large populations that can really reach and make an impact on at a population level, which is what we need to do to reduce suicide rates at a meaningful level. Looking onto slide 5. Currently, I'd say that the suicide prevention field is strongest in identifying lists of risk and protective factors. That's what we often see, these kind of proximal risk factors or warning signs, depression, drug abuse, and suicide prevention has been guided a lot by how do we reduce those factors in order to reduce suicidal behavior. And if we look at over on slide 6 here, these are some illustrative programs that have promise as suicide prevention programs during different prevention window periods, childhood, early adolescence. And we have effective programs that can reduce or risk factors or strengthen these protective factors that are associated with suicidal behavior during adolescence and early adulthood, and they also make a difference throughout the lifespan. There is one notable exception that has shown effect on reducing suicidal behavior in a meaningful way, and that's the good behavior games, strengthening children's classroom self-control. And I'm going to be talking about that a little bit later. If we go on to slide 7, so current models, if we come back to our list of risk factors and think about early prevention programs, they're relatively strong in enumerating kind of the processes, the approaches that can reduce and change these risk and protective processes. We have programs that can reduce drug abuse, strengthen peer and family relationships, increase coping skills, and particularly those that can reach large numbers of children and adolescents. But where we're weak so far is in integrating that early prevention with models that really put together what are those most important topics, what are combinations of risk factors, what are the, as I think Tom has such a nice way of showing that, that the overlap of these different risk and protect is small. We need to have good targeted models, and I think the interpersonal theory is one that has some major implications for this. So going on to slide 8, some of the implications is it points to the importance of strengthening through early intervention belongingness. So those strengthening family systems, strengthening children's peer socialization to school, reducing peer aggression and harassment and experiences that will disrupt that belonging, promoting the healthy functioning systems that can increase connectedness between youth and systems with caring adults. I think the other area it really points to is the importance of strengthening self-regulation processes. As I mentioned earlier, those skills where children learn how do you manage behavior, control impulsivity, deal with emotions that are painful and overwhelming in ways that don't initiate those self-harm behaviors, which once initiated can become very difficult to reverse and become reinforcing and have other kinds of emotions experienced with them, which is, I think, again, a major innovation of Tom's work. I think another implication of the interpersonal theory is it points to adolescence as a critical prevention window period. Self-harm behaviors have the highest frequency during adolescence. Suicide rates, attempt rates have the highest rate during adolescence, or at least certainly the largest escalation. And ITSB, the theory would suggest that reducing the emergence of these self-harm behaviors, whether they're non-suicidal self-injury or more suicidal, could have a dramatic effect on reducing those who are entering those pathways to lethal self-harm. Going on to the next slide, I wanted to show this as an illustrative example of why increasing connectedness to systems and changing social environments might make a difference. This is an example of a social network in a school that's currently participating in a trial that we're conducting, and this is a map of all the interpersonal connections, the best friend connections between students at this particular school. So students are asked to nominate who are your close friends, and across 30 schools, we found that those students who said they had made a suicide attempt or an attempt with injury were far less likely to be closely connected, those students that are in the center, that are part of those tight networks. And in fact, students that attempted with injury, where, as I think Thomas would suggest, that's a group at particularly high risk, were about 2.5 times more likely to be isolates compared to students that were matched in other ways, and also less likely to be connected to adults. So I think we need to be thinking about interventions in not just at the individual level, but really at the systemic level, and how we can modify these the experience of children in social systems. And I think Tom's work really points us to that. I think the interpersonal theory might help us understand the good behavior game, and that's really another very important area of research that has shown that this program implemented in first and second grade classrooms, urban classrooms, where teachers promoted groups of students working together using peer reinforcement to reinforce positive behavior. And the good behavior game by age 19 or 21 had reduced antisocial behavior, substance abuse, and by about 1/2 rates of suicidal ideation and attempts based on self-report. This early work, Holly Wilcox and Shep Kellum and colleagues, they did not yet identify what are the processes through which the program reduces suicidal behavior. And I think the interpersonal theory can help guide that by suggesting that it may affect socialization, perceived belonging, less maybe vulnerability to disruptions in social relationships, and importantly, through self-regulation that promotes coping and reduces the transitions to patterns of self-harm. And I think having that kind of specificity in the model can be important in testing that intervention and others that may be like it. Slide 11, my last slide. I think there's so many things that would be interesting to talk about with this model. And one thing that occurred to me is, can this model also help us to understand some other aspects of developmental theory and vulnerability? There's a lot of evidence that harsh early life seems to, or is a empirical fact, is associated with increased risk for suicide across the lifespan. And we don't know very much why. There's been talk about certain genetic, genetic changes in genes, in physiological, phenotypic changes. But the life history theory is an interesting one that suggests that harsh early life tilts individuals towards a fast life, where there's less investment in long-term orientation, relationship commitments. And I think the interpersonal theory could help to illuminate how those things might occur by making individuals, again, less connected, less likely to have that kind of close and protective relationships, and an orientation that decreases the likelihood of entering self-harm patterns. I think another, I've mostly been talking about early prevention and really with large groups, but I think also the interpersonal theory raises some really interesting and important questions about self-harm processes and how those can become rewarding. The opponent process aspect, which is very innovative, and I think that's one that also points us to really needing to think carefully about how do we incorporate that model? How do we address and use strategies that can reduce that escalation and maybe provide alternatives or directly reduce the reinforcing aspect of self-harm? And I think that's I'm sure Thomas has given thought to that. I'd be interested in his thoughts about it. So I wanted to go through a bit quickly to give other people an opportunity to ask questions and make comments about Dr. Joyner's important work, and so I'll stop there.
Thank you very much, Peter. And before we open up to the audience for questions, maybe Thomas, if you wanted to take a moment or two just to share any reflections on Peter's discussion, you'd be welcome to do so.
Sure. I would just add that I intended the theory to have kind of a life of its own, to go out and to inform clinical work and risk assessment and also prevention. And it's just gratifying to see that it's got potential to do that, not only in my view, but according to one of the leaders in our prevention field. Beyond that, I think the points that they just seem very clear to me, and and compelling, and I'm very excited about the future in terms of applications of the theory and related concepts to, what really matters at the end of the day, at least to me, and it's preventing suicides in the future.
Thanks so much, Thomas. So with that, why don't we open it up to the audience for questions?
All right, thank you. At this time, we're ready to begin a question and answer session. If you would like to ask a question, please press the *1, and please record your name. To withdraw your question, press *2. Once again, *1 to ask a question. One moment. Once again, press *1 to ask a question.
And let me ask, one thing I don't recall is whether we have the capacity for submitting questions online.
No, there are no questions on the phone.
Well, let me ask one question then. Peter, one of the things that you mentioned in your response really had to do with emotional regulation processes, which there are certainly important reasons to think not only in Thomas's theory but in other work to be significant for suicide prevention. So, for example, in dialectical behavior therapy, the teaching of emotional regulation skills is a key component of that therapy, which has been found to reduce suicide attempts and days spent in the hospital and achieved other positive outcomes. Peter, could you say a little bit more about your thoughts about the role of these kinds of desensitization processes, if I'm understanding your point correctly, with the field or the study of emotional regulation processes in general, which I'm certainly less familiar with. So maybe you could just expand a little bit on your point.
Well, I think there is compelling evidence that challenges in self-regulation, the experience of overwhelming emotions, is a major factor in how patterns of self-harm can develop. So, I think, as for example, individuals who need to find relief through initiating, and I think this theory is really adds something important in that, showing not only how those can be momentarily relieving of a painful emotion or an overwhelming experience, but also how those can become reinforced, escalate. So I think skills that help individuals to be able to do all those complex things that largely become very automatic and learned, that are part of self-regulation, self-soothing and calming and seeking help and using language and all those things that are particularly critical during middle childhood or the relationship outside. They're really part of increasingly independently. So I think the ties are really clear, and for how those difficulties can really escalate these self-harm trajectories.
Okay, we do have some questions on the phone now. Willa, go ahead.
Oh, I'm sorry, is this me? Okay, I'll go for it. I have kind of a very general question. I work in suicide prevention in a small town in South Dakota, and we need to become more deliberate in the research we're conducting, which I have the background for, but in suicide research, I'm not quite sure how to go about getting the data we need to look for correlations between variables that increase or decrease seem to, with suicide, and was wondering if you could direct me toward the types of data I'm looking for.
Are you looking for local data or national data?
Local and regional. I mean, in South Dakota, we have so many small towns, and our population is small. Ideally, we'd like to have state data, but local as well. And I'm not exactly sure where to connect. I know that here, honestly, we need to be kind of careful to go through the right channels on our first try, because going through the wrong channels sometimes shuts a lot of doors for us pretty quickly.
Yeah. Richard, do you have any, are there grantees in South Dakota or connections that you're aware of?
Well, South Dakota has received a Garrett Lee Smith grant, and we could certainly help you connect with some of the people who have been involved in that. Another thing to be thinking about, although it only really helps with older teens, younger adults, is that SAMHSA's National Survey on Drug Use and Health has state-by-state breakdowns on state-by-state estimates for those who report that they seriously are have seriously considered suicide in the past year, that have made a plan, that have made an attempt, and that have made an attempt that required medical intervention. So each of those is available on a state level. The limitation on that is that the National Survey on Drug Use and Health only routinely asks those questions of those 18 and over.
Okay.
So it doesn't get to the younger one. Now, the questions are actually very similar, if not identical, to those that are asked by the Youth Risk Behavior Survey, which is looking at high schools. I'm less familiar with how to best access that data on a statewide basis. I know there are some efforts to protect the kind of confidentiality of individual schools so that they're not easily identifiable.
Sure.
But you can certainly be in contact with CDC and with Dr. Alex Crosby to find out more about what's available within South Dakota regarding youth risk behavior survey data. The other source of data that I'm aware of would have to do with tribal communities, where those who present to services through Indian Health Service, the Indian Health Service has a system for collecting that data. Well, but that wouldn't be for the state at all. That would be specific to tribal communities within South Dakota.
Sure. Okay, that's a wonderful help. And you said it was Alex Crosby at CDC?
Yes, that's correct.
Okay, wonderful. Thank you.
You're welcome.
I'm sorry, and the question is from Willa Cass-Stevens.
Hi, and thanks. I really appreciated the presentation today. I was wondering, currently I'm an associate professor at NC State in Raleigh, but for about 15 years I worked in mental health in South Florida, and I did quite a bit of work with folks with pretty serious eating disorders and other folks that were engaged in self-harming behaviors. And I was wondering, I thought the model really addressed that, the self-harm becoming more and more appealing and a more and more difficult habit, if I can put it that way, to break, aspect of that behavior. I was just wondering, did you view that as on a continuum to suicide behavior, or is it simply that folks that engage in those behaviors have such a reduced fear of harm that they become at higher risk, if that makes sense?
Yeah, it makes a lot of sense, and we definitely view it as the latter. In other words,
thank you. Okay.
Yeah, we view it as a conduit to building up that fearlessness part,
okay.
and we don't, by contrast, view it as part of an overall continuum. It could be. This is an empirical question, but my take on the empirical literature is that the continuum idea of, on one end, behaviors such as, self-cutting for the purpose of mood regulation, all the way on up to the other end of serious near lethal attempts or death by suicide, that continuum model doesn't hold up particularly well empirically. So that's our current view on the matter. With regard to eating disorders, I would just add a little bit of detail. There, we have good data that the anorexic folks are more vulnerable than the bulimic folks, as I noted. And then within anorexia, there's a group who are doing a lot of, they're anorexic, but they're also doing a lot of binging and purging. And there's a distinct group who aren't doing much binging and purging. They're just doing a lot of restricting of intake. Mm-hmm. They're very vulnerable, but the ones who are the most vulnerable are the anorexic binge purge folks. And the way that we understand that is they're amping up their fearlessness levels because they're doing all of the above. They're doing restricting. They're doing very hard exercise, which we've shown empirically is one of the fastest routes to this fearlessness. When you're exercising, way beyond capacity, even when you're badly injured, that kind of behavior. Mm-hmm. They're doing that. But they're also doing the binging and the purging. They're doing everything, and it's consistent with the model that they develop the highest levels of fearlessness and are the most at risk for serious suicidal behavior.
Thank you, and that goes along with my practice experience, but I've learned not to overgeneralize these things.
Sure.
So I appreciate the feedback. Thank you.
You're welcome.
All right, next question is from Paige Chiatella.
Hi, it's Paige Chiatella at NIAAA, and I'm wondering if you can suggest any ways this theory may address suicidality among returning veterans with PTSD?
Yeah, I'd be happy to address that. I think that a couple of things. One is that for some returning veterans, certainly not all, but for some, the transition from active duty to veteran status can mean a loss of connection to people with whom the service member became extremely close. For instance, during combat, those extremely close relationships can, for some people, fade a little bit. And also, for some, not all, the sense of purpose and of mission can take a hit when somebody transitions out of the service, unless they're able to find new challenges and new opportunities for employment. And we feel that based on some of the work we're doing with the DOD and also through the lens of this theory that the ones we're very worried about with regard to suicide risk are people who are having those transition problems, specifically in replacing the close connections they felt and also in replacing the sense of purpose and mission. That's the bad news. The good news is that, consistent with Dr. Wyman's remarks, there are prevention avenues that are implied there. For instance, a very down-to-earth one that I find compelling is employment programs that link veterans to satisfying work. Those have a lot of potential for doing a world of good, not just with regard to suicide risk, but across the board for health and mental health. So that would just be one example of it, and it would be easy to imagine others where if you make any progress at all on the points of belongingness and the opposite of burdensomeness, namely having a mission, then you're gonna, if the model holds any weight, then you're gonna reduce suicide risk thereby.
Fearlessness must be one of the strongest points in training. Is there any way one might be able to reverse that aspect?
It's a really great question that we've pondered deeply over the years. I mean, in principle, there's no question that you could do it, in principle. In practice, it's so complicated and ethically difficult that we're not sure there's much potential there clinically. But there's no question that you can reinstill fear of anything. And there's studies that are real clear that there are a lot of ways to do that directly, vicariously. People who are afraid of spiders, for instance, that you can have them lose that fear, and then if they see somebody, confronting a big spider and that person has a very fearful reaction, their initial fear gets reinstated a little bit. So in principle, there is something there. There's a path forward there in principle, but in practice, it gets so complex that we just haven't pursued it because we're just worried about those clinical complexities.
Thank you.
And I believe Chelsea Booth has some online questions that have come in. Chelsea?
Thank you, Richard. So our first question comes from Deb. Does burdenness and belongingness vary by age? I can imagine older adults might feel more of a burden.
That's certainly possible that that's true, and that would square with the age structure of death by suicide. In other words, the fact that it's more or less a phenomenon of the last half of life. But I would also, just remind everybody that it's certainly possible for young people to feel, certainly they can feel lonely and alienated. There's no question about that. But there's also a lot of young people who do feel a sense of burdensomeness. Now, when they talk about it, they'll phrase it differently. It won't be what like an older adult might say, where, for instance, an older adult may say, I no longer feel like I'm a breadwinner for the family, or things in that direction. For youth, it can often feel like I don't feel like I contribute anything to my society or to my family or to my friends. But, the core idea, at least according to the model, is that across ages, it's these two states of mind that instill the desire for death.
Okay, our second question online comes from Kim. Kim says, I'm curious about the interaction of the level of psychic and or physical pain and interpersonal factors. Might very high levels of psychic or physical pain override some of the interpersonal factors?
It's certainly possible, and on that point, I'd like to say that we truly are interested in challenges to this theory. We really want it poked and probed and scrutinized, because our agenda is not theory. Our agenda is preventing death. And if the theory is a valid way to do that, then so be it. But if it's got flaws or problems, we really want to know about that. So that's just one general point. On the point of psychic versus physical pain, the way the theory has treated that is that it acknowledges that, psychological pain is important. And what it does is try to really specify which forms of psychological pain are the most important. And the theory's conjecture on that point is that the most important forms of psychological pain are burdensomeness and low belongingness. On physical pain, that's really relevant to the other side of the model, the fearlessness part. If you become very, very acquainted, for whatever reason, to physical pain, you're going to be less afraid of it, less daunted by it, and that could have real clear relevance to an increase in fearlessness and therefore an increase in risk for suicide.
All right, and our last question online asks, are there other treatment modalities in addition to DBT that have the potential for suicide prevention when working with individuals?
I think there are a number. I'm going to make one quick comment, and then I would invite, if he wants to, Dr. Wyman to talk a little bit more about the good behavior game, because it's simple, it's down to earth, and yet its effects are impressive. And unlike DBT, for instance, and some other psychological treatments, which are pretty complicated and difficult for the run-of-the-mill everyday clinician to employ, these kinds of things are easier. And the one that I would point to is a treatment for depression. Its effects so far have not been very well characterized with regard to suicide prevention, but my suspicion is that there would be some traction there. And the treatment's called behavioral activation. And just like the name sounds, all it involves is gradually getting people more active, more engaged in things that they find at least mildly rewarding. A lot of attention is paid to their sleep schedule. And just those changes alone, as simple as they are, can have far-reaching clinical and other benefits. So I'm real attracted to treatments like that are down-to-earth, usable, portable, and yet have really strong effects, at least with regard to depression. Again, it hasn't been well characterized as a suicide risk intervention.
Yeah, I might just add, from the standpoint of preventing suicide down the road, years later, I think a number of interventions that strengthen parenting and parent-child relationships also have a lot of promise in promoting those capacities for relationship strength and connection, and also because positive parenting helps to promote these kind of self-regulations. I think interventions that work with children in families at elevated risk due to various kinds of stress or divorce, for example, or loss by death, bereavement, really have some potential. So that might be something else to think about.
Great. Thank you very much. I'll just mention one other thing, that in terms of treatments per se, in addition to dialectical behavior therapy, cognitive behavior therapy is researched by Greg Brown at Penn, and there are some other treatments that also have some data supporting them. Multisystemic therapy for adolescents is another one. If you go to SAMHSA's National Registry for Effective Prevention Programs, or NREP, and you search under suicide, there are about 20 different suicide prevention programs. Some of them are prevention specific, others are treatment and interventions that are listed, and it gives you information both about the data supporting it, as well as how they can be accessed and what kind of materials or support are available for dissemination of the approach. So I would call that to your attention. So I know we've gone over our 12 o'clock ending time, so we'll cut off the questions here. Let me thank once again Dr. Joyner and Dr. Wyman for their participation in this webinar. I think it's been a great opportunity to talk about really the most important, I think, contemporary theory around suicide prevention, as well as the implications for moving it forward. And I think it's been an exciting webinar for all of us. And before we sign off, Chelsea, can you just let people know where this will be archived?
Sure. For those of you who registered, the link where you should have received a link, but I will make sure to send out the link. It's available on the Suicide Prevention Resource Center's website, which is sprc.org, but you'll receive an email from me, Chelsea Booth.
Okay, thank you, Chelsea. And again, thank you, Thomas, thank you, Peter, and thank you for everyone who participated. And with that, we will end this webinar.
All right, thank you. This completes today's conference. You may disconnect at this time.